Hi, welcome back. Good afternoon all. So now is go to the most exciting parts of this APCASH symposium. It's Keynote Lecture 2022. Will be delivered by Professor Lars Sondergaard, a world-famous TAVI operator and different structural heart intervention. In this session will be moderated by me, Gary Zheng, and also Dr. Vincent Lo. And also we'll have Danny Zhao and also Ivan Wong as panelists. So I would like to ask Vincent to introduce Professor Lars Sondergaard.
Thanks, Gary. So I will make it short because when we talk about Lars, that's I can spend an hour to introduce him. So Professor Lars Sondergaard is currently a consultant cardiologist of Rigshospitalet, Copenhagen, Denmark, and also the professor of cardiology of University of Copenhagen, Denmark. His special interest is congenital as well as structural heart disease, particular interventional procedure. He leads many first-in-man transcatheter procedure, including transcatheter mitral valve replacement, Gore septal occluder for ASD PFO, and also the hydro valve for TAVI, and also Omega for airway occlusion, and a few more. His research interests are focused on adult with congenital heart disease and transcatheter-based heart valve intervention. He's the PI for several randomized clinical trials, including Tempo trial, Notion 1 and Notion 2 trials, Notion 3 randomized trial, the reduced randomized trial, as well as the Galileo 40 trial, and further some more. So I'm just going to make it short. So, Gary.
May I supplement a little bit? Yeah, hi Lars. Lars has a very long and good and close relationship to Hong Kong, especially in the development of TAVI in Hong Kong. Since the first APCASH back to about a decade ago, Lars already helped us our APCASH every time, either physically to attend the symposium to share his valuable experience in TAVI and structural heart disease, and also as a live case transmission center from Copenhagen. Moreover, not only APCASH, in the past 10 years, 5 cardiologists from Hong Kong joined Lars Center, being under advanced training in the field of structural heart disease intervention, including me, myself, Vincent, Danny, and Ivan, and also Albert Wong. We all spent 1 year in Copenhagen to learn a lot from Lars and also his team, and then bring all the advanced latest development of structural heart intervention skill and technology back to Hong Kong. So I think Lars is a very important person in the field of development of the structural heart disease TAVI in Hong Kong. So without further delay, I would like to ask Lars to share his 20-year journey of TAVI. Thank you, Lars.
Yeah, thank you, Gary, and thank you, Vincent, for the kind words. I'm sorry I cannot be in Hong Kong today, but next year maybe. So 20 years of journey is a very broad title in only 15 minutes, and I'm just going to give my view on how it is today and a little bit how I think it's going to be in the next years. So it actually started not only 20 years ago, it started even before that, back in 1989, 33 years ago. This Danish guy, Ole Andersen, got this crazy idea that he could make a heart valve and treat patients with aortic valve disease. He showed that it was possible to do it using this TAVI concept in animals, in pigs, both in the descending aorta, but also to implant the valve actually where we're doing today in the aortic annulus. And if you look at Henning's transcatheter heart valve, you can see it's very pretty much the same as was used for the first in human case 13 years later. A stent he made himself, and a heart valve which he bought from the butcher, a pig heart. He took the aortic valve out, he rinsed it up and shoot it into the stent and crimped it on the balloon. And that was actually the concept which paved the way from Alain Crébier, who 20 years ago did the first in human concept the first in human case in France. But I think everyone today recognized that it was based on the idea from Henning Rud Andersen 13 years earlier. So how has this journey been? First of all, I would say it's been a lot of evidence to prove that this is a good therapy for the patient, starting out with patient at extreme surgical risk, really old, very sick patient who were turned down for TAVI. And these were the patients we actually started out with when it was approved in Europe back in 2007. And there was a lot of discussion whether this treatment made any difference from these patients. As you saw here from the first part of 1B trial, that offering these patients TAVI instead of just best medical treatment, you had a 20% absolute reduction in mortality after 1 year. So a therapy which many other therapies can actually match with a 20% reduction in mortality. Afterwards, we have seen a number of trials against surgery, both in patients at high risk, intermediate risk, and low surgical risk. And in total, we have 7 randomized trials now with a total of 8,000 patients. And if you look in this meta-analysis, how are TAVI performing against surgery with regard to all-cause mortality at 2 years, you can see that if you send the patient for TAVI instead of surgery, you got a 12% reduction in mortality. And actually, if the patient is going for what most of us do today, a transfemoral approach, it's almost a 20% reduction in mortality for patients coming to TAVI instead of surgery. And that's also from the same meta-analysis applicable with regard to stroke. Stroke is reduced with 20% for patients going to TAVI instead of surgical aortic valve replacement. And it's not only the evidence, but also the whole concept, the development, how we do this procedure have changed. All of us started out doing these procedures in general anesthesia. Today, it's done in local anesthesia. We don't even have an anesthetic team in the room. In the beginning, most sites could do 1 or 2 cases today. It's not uncommon that sites will do 4 cases a day in the same room. We also have quite a few complications, particularly vascular complications. In the beginning, nowadays, these complications are more rare, and we can easily handle them by ourselves in the cath lab. And most sites will run with a 30 days mortality of less than 1%. Pacemaker rate was high. It's approaching the rate we see after surgical aortic valve replacement. In the beginning, it was a quite long hospital stay, patients starting out in ICU and then spent more than a week in hospital. Today, these patients are going straight back to the ward, and most patients in Copenhagen, is more than 80% of the patients will leave the hospital and go back to their own home the day after the procedure. So certainly there's been an enormous development in this procedure. And this has also led to change in guidelines both in Europe and in the US. These are the American guidelines from 2020. And you can see it divides patients up in 3 groups. Patient younger than 65 years of age go for surgical aortic valve replacement. Patient older than 80 years of age should go for TAVI. And then you have this big and maybe most difficult group between 65 and 80 years of age, where you, for all these patients, should consider surgical aortic valve replacement. So even in patients down to 65 years of age, you should consider TAVI. And I know, and I just heard last week in London, at London Valve, that actually half of the patients in the US who are below 65 years of age today will go for TAVI. So it's certainly moving down. And according to the American guidelines, there's nothing about risk in these guidelines and recommendations. It's only 2 factors you need to consider. What is the life expectancy of the patient, and what is the durability of these valves? But again, if you're going to move down to patient at a younger age, we're also going to treat patients with longer life expectancy. And some of the complications we in the past regarded as benign may not be benign if you treat very young patients. One of the issues is new onset conduction abnormality, permanent pacemaker. And we all know it's down to the close proximity between the aortic annulus and the AV node. It's actually only separated by the membranous septum located between the right and the non-coronary cusp. So the deeper the implant this valve, the higher will the risk be for new onset conduction abnormality and new permanent pacemaker. So today everyone wants to implant higher, of course, without having the risk of a pop out. And one thing which has been introduced in almost all cath lab is how we do this valve implantation. It's actually quite simple because it's all about where we position our C-arm during the implantation. And I think most of us starting out having the C-arm in a LAO cranial projection, like a three-cusp coplanar view, but have now moved to this right-left cusp overlap view, which is often in an REO caudal projection. It's a projection which can be determined from your pre-procedure CT scan. And that actually means in this projection that you won't have any parallax in the delivery system, and you're still going to have the aortic cross in the same imaging plane. It's illustrated here. We all know the S-curve for the aortic valve, and we all started out here looking for the three-cusp coplanar view, often have some parallax in your delivery system, and then we took the parallax out, moving down to the S-curve for the delivery system. But that's just going to introduce the same tilt in the aortic annulus than there was in the parallax. So going down to this REO caudal projection, we ideally want to be in this double S-curve crossing, where we have the three aortic cusp aligned with imaging plane and no parallax in the delivery system. Even though the cusp overlap view will not be perfect there, you see the ideal thing about this is that the distance between the two curves are now very small. So we introduce very little parallax here. And that certainly have made a big difference with regard to pacemaker. These are data from Copenhagen, almost 200 patients matched in each group. And you can see using cusp overlap view, we actually reduced the pacemaker rate with 50%, coming down from 15 to 8% at 30 days. Another issue when you treat patients with longer life expectancy is that you need to be able to access the coronary arteries afterwards. You can divide all TAVI valve into three groups: low stent frame with intra and leaflet position, or high stent frames with either intra or supra-annular leaflet position. And even though it may be quite easy to access the coronary arteries for these two types after TAVI, we know particularly for if you have supra-annular leaflet position, it can be difficult. We have seen from the VXS study that if you have an evolute valve in place, it's about 1 out of 5 patients where you will not be able to access the coronary arteries after a TAVI procedure. And the problem is that often if you don't pay attention, this valve is going to be implanted in a random way. We can end up in a position here where we have the leaflet post right in front of the coronary arteries. And again, particularly if you have a supra leaflet position, it may be difficult or even impossible to access the coronary arteries. So what we should aim for is the same as the surgeon will do, having commissural alignment. Align the transcatheter heart valve the same way as the native annulus. That's going to make it more easy to access the coronary arteries, and it's probably also going to improve the durability of these valves. How can we do this? It's been suggested that changing the way we are introducing this delivery system into the patient. Medtronic, when they launched their system, recommended that the first port should be at 12 o'clock, pointing towards the ceiling of the room. Gilbert Tang said if you turn the flush port to 3 o'clock, pointing towards the left side of the patient, it's going to reduce the risk of commissural misalignment. And he actually proved that. So if you have it at 12 o'clock, you have a 40% severe commissural misalignment, coming down to 20% if you have introduced it at 3 o'clock. So it's a 50% reduction, but it's still 1 out of 5 patients where it's going to be difficult or even impossible to access the coronary arteries. So we need to do it better. We need to do what I call patient-specific commissural alignment. And using this left-right cusp overlap view is actually a very nice view if you want to have patient-specific commissural alignment. Because in this view, you have the C-arm here, right and left cusp is overlapping, and you can see that the commissure between these two cusps is pointing to the right of the fluoroscreen. Also illustrated here, right and left cusp are overlapping, commissure is pointing to the right. So the only thing you need to do is to position one of the leaflet posts on the right of the fluoroscreen in a left-right cusp overlap view. It's illustrated here with the accurate valve, which is probably the easiest valve to do this. You have very clear markers. Where are the leaflet posts? You have the post here on the top. You also have this free stent strut. So one set here should be on the right side of your fluoroscreen, and the two others should be overlapping on the left side. And again, if you're working in a right-left cusp overlap view, it's quite easy to see it. If it's not the case, you do some torquing on the system and it will slowly rotate until you have it. When it's obtained, you just start deployment of your valve and you have patient-specific commercial alignment. Another issue is the stroke. I said the stroke is about 20% lower after TAVI than after surgical aortic valve replacement. But this is often the complication the patient fear most. Elderly patients are maybe not as afraid of dying during the procedure, but having a disabling stroke is a really big concern. And we have introduced these cerebral embolic protection devices, both filters like here in the Sentinel and deflection devices as in TriGuard, sitting there during the procedure. And we have seen a number of the studies that the catch of these filters are almost in 100% of the patient. It will also reduce the number of so-called silent lesions in the brain. Recently, we saw this protected TAVI trial, 3,000 patients undergoing TAVI, randomized 1-to-1 between TAVI alone or TAVI with cerebral embolic protection using the Sentinel device. Patient was assessed by a neurologist before the procedure and after 32 hours or at discharge, whichever came first, for any stroke. And maybe a little bit disappointing, it came out neutral. There was no significant difference in the primary endpoint of all stroke, came down from 2.8 to 2.9% with the filter. But disabling stroke as a secondary endpoint was a significant reduction from 1.3 to 0.5%. So certainly it will reduce disabling stroke. The number needed to treat is pretty high. It's 125 patients you need to use the filter to prevent one stroke. But in our institution, where we do around 500 target procedures a year, it means that 4 patients every year will be saved or salvaged for a disabling stroke. So let's see where this story ends. We also have the Protect TAVI ongoing in the UK, similar design, now with more than 7,000 patients. So a meta-analysis is going to give us more than 10,000 patients, and it may have power to show there's a significant difference also for all strokes. Finally, we have to consider lifetime management when we treat patients at a younger age. The patient we have started out treating is quite old, around 80 years of age in most studies on registries. And if you assume that this patient is going to live till he or she is 85 years, then the remaining lifetime is 5 years. And even though we don't know the exact durability of these transcatheter heart valves, and they're probably going to be different from valve to valve, we can just assume it's around 10 years. So you can see today, durability is not a major issue because the valve is going to survive the patient. But if you're going to follow the American guidelines and the trend which is already happening in the US, going to much younger patient, even patient down to 60 years of age, and that patient is still going to live to age 85, that gives us a 25 years remaining life expectancy. So we can see if the valve durability is 10 years, we will need at least one, maybe several revalving during the lifetime of the patient. And of course, that needs to be considered even before we choose the first valve. So it's important treating patients with longer life expectancy. Start thinking before you make the first implantation. Choose a valve which have a good durability. Avoid patient-prestige mismatch, which is the biggest driver for this, and also a valve where you can safely perform valve-in-valve procedure later on when it's failed. And that means safely mean that after valve-in-valve procedure, you should be able to access the coronary arteries. So first of all, how do you choose a valve with a good durability? These valves are designed differently. So you may also expect that hemodynamic performance afterwards is going to be different. You have the portico of the navigator valve, which is a cylindric inflow portion where you have the leaflets opening up 90 degrees. You have the evolute platform with a taper stent configuration, which is also going to restrict the opening of the leaflets. And you have the Sapien platform, which is based on the Edwards surgical valve, where the leaflets are actually tapered. And you can see here, if you look at this randomized trial from the US, the Portico IDE, and only identified patients with small aortic annuli, 23 millimeter or less patients who are particularly at risk for patient-prestige mismatch, and look at the degree of patient-prestige mismatch at 30 days, we can see here for the Portico, it's 3% who got severe PPM, same as for the evolute. Whereas if you go for a balloon expandable, it's more than 25% of the patients. So again, having a patient in front of you with a smaller aortic annulus, remember that PPM is can be the consequence of choosing a valve, a balloon expandable valve. To choose a self-expanding valve, it doesn't matter whether you choose one with intra or supraannular position. If these valves are going to sit long enough in the patient, they will eventually fail, and you have two options. You can send the patient for surgical explantation and implantation of a surgical valve, or you can do a TAVI procedure. And we have seen data that the explantation of these valves is often not easy, often involving routine replacement. 30 days mortality is more than 30%. It's much lower for TAVI procedure, despite it's not the same number as for TAVI in native aortic annulus. In the beginning, my idea was that when the one valve was failing, I was going to implant another valve of the same type inside. When you implant a second valve, you're going to push the leaflet from the first valve aside, and you're going to create a tunnel of tissue and new skirt, which may not be a problem if you have an intra-leaflet position. You will still be able to access the coronary arteries. But if you have a supraannular position, you're going to create a tunnel of tissue extending from the left ventricular outflow tract through the sinus of Valsalva and into the ST junction. So it may even impair or occlude the coronary arteries immediately after, and it's going to make it probably impossible to access the coronary arteries later on. And this is, of course, going to be an unacceptable complication if you treat patients with longer life expectancy, that you cannot access the coronary arteries when they come back for, let's say, acute coronary syndrome. So I think what people are considering today is to use the second valve, use a balloon expandable valve. You can implant it in different positions, high, intermediate, or low. The lower you implant it, the shorter is the new skirt going to be, and the easier it's going to access the coronary arteries. The cost will be that you're going to have more leaflet overhang from the first valve, which potentially can impair the hemodynamic performance after a TAVI procedure. So just at the end, how's the future going to look? We have seen that there's trial ongoing to try to expand the indications for TAVI. What about patients who have severe aortic stenosis but still do not have symptoms? Are these really benign, have the same prognosis as a patient without aortic stenosis? It seems not. So we now seeing patients, studies randomizing patients to TAVI or watchful waiting. The early TAVI trial is already completed. We'll have the data within a year. It's going to be very interesting whether we should change our guidelines and how we handle these patients. Another indication could be patient with moderate but severe aortic stenosis, could be patient with heart failure, should be treated early on. Expand TAVI-2 is a trial, randomizing patients to, again, only best medical treatment, or adding TAVI to it. So potentially, again, to expand the indication. So again, it's been 20 years. I hear that quite a few of my good friends, Gary, Vincent, Ivan, Danny is in the room. We also have Ronnie now with us in Copenhagen. And my relationship with the physicians from Hong Kong go many years back. I just found this picture here a few days ago with some of the first people who actually started out with the TAVI program in Hong Kong. So I hope certainly we can keep this connection and share knowledge and best clinical practice between Copenhagen and Hong Kong. Thank you.
Thank you, Lars. Definitely, I'm totally agree that we will still keep this kind of relationship. So now we open for discussion. So Danny, you have a question, right?
So I'll start. Hi, Lars. We've talked about the 20 years of TAVI in the past. So how do you see TAVI going forward in 5 to 10 years' time?
I see that TAVI is going to be even more refined as it is today. We have seen during the last year that the way we execute this procedure has been refined. I talk about commercial alignment. I talk about cross-bore view to avoid the patient-prestige mismatch. So the procedure is going to be more refined. We're going to see new devices, even better generations devices as we have today. One device, which I didn't mention, was the Jena valve, particularly designed to treat patients with aortic regurgitation. Hopefully we'll see more evidence to actually support us to move to patient at a younger age. We don't have that evidence today from the two low-risk trials, Partner 3 and Evolute Low Risk. Mean age was 73, 74 years of age. So we need studies at patients at younger age. We have the Notion 2 trial, which is completed now. Mean age is around 70 years of age. And also one unique thing here is that it's the first trial which include patients with bicuspid aortic valve. So hopefully also we can treat patients with bicuspid aortic valve. But I think the journey has already started. With or without evidence, TAVI is going to expand to younger and younger patients. It's going to be the first line treatment for patients with isolated aortic stenosis. And then again, it's probably going to open up for new indication. Patient with severe but still asymptomatic aortic stenosis, moderate aortic stenosis. What about aortic regurgitation? So we will, and on the top of that, we're going to see much more patients coming forward, because this baby boom we saw after the war, these patients are now turning into the age where we see patients with TAVI. So it's going to double or maybe even triple within the next 10 or 15 years, as I see it.
May I follow Danny's questions? So, Lars, what is your ideal TAVI device? Any requirement or prerequisite for being an ideal TAVI valve? And currently, is there any commercially available TAVI valve should or best fit your requirements?
First of all, I would see there's a number of very nice devices on the market, and they all serve 80, maybe 80, 90% of the patient very well. And then you have your specific patient where you need to consider which device should I use. I just talk about if you have a patient with a smaller aortic annulus, make sure that you give the patient a valve which have a good hemodynamic performance and thereby a good durability. Also a device which is well suited for a valve-in-valve procedure later on. So I think you cannot really say which device is best out there. I think you need to make it patient-tailored. Also, one thing you should take into consideration, some sites still do not have a very large program and only have one, maybe two valves on the shelf, that you cannot master all valves. You also need some experience yourself with the valve, so you actually can implant this valve in an optimal way and don't have too many complications.
Yes, there are a question from the floor. So, Mike, please. There's a question from Dr. Maria.
Hi, Dr. Lars. I'm a pediatric cardiologist. I'm not doing TAVI, but I have a query now. For TAVI, it's recommended not to do below 65 years old. But in children, we're doing transcatheter pulmonary valve implantation for those young adults. So I'm wondering, is there any major difference in the material and structure of the two prosthetic valves?
That's a very good question. And I do pediatric procedures myself and also adults with congenital heart disease. I think that all the things we're doing in the structural field nowadays could certainly be applied to some of the patients with congenital heart disease. What about the young patient who have a degenerated bariatric aortic valve and have multiple surgery in the past? Why don't do a TAVI in this patient and at least delay the time where you need to intervene? What about edge-to-edge repair with a MitraClip or Pascal in some of these patients who have a high risk for redo surgery? I think that could also be doable. So again, it's right. It's said that 65 years age was lower, but again, you saw it's about life expectancy and durability of these valves. And I think for some of these younger patients with significant or severe congenital heart disease, the life expectancy is not going to be 50 years despite their 30 years of age. And also redo surgery, some of these patients is going to be associated with a very high risk.
Thank you. Thank you.
Last, I would like to ask you a question about the development of TAVI in Hong Kong. Since the first TAVI in Hong Kong is already more than 10 years. However, of course, in the past decade, the number of TAVI increased a lot. But it seems that in the past few years, it already reached to bottom leg phases of the development. So, of course, there's a lot of different reasons, like the cost of the equipment or education, something like that. So, is there any insight or any opinion you can share with us how we can improve the development of TAVI in Hong Kong?
How you can improve the volume of TAVI?
Oh, yeah, also, yeah, and also.
Yeah, I mean, again, there's several factors. First of all, you need the evidence. I think the evidence is there now. We have seen very safe procedures and can even certainly match surgical aortic valve replacement. And then you need awareness of the therapy. I think most sites nowadays, most cardiologists know about TAVI procedure. And then there can be an issue about reimbursement. Can you convince your health authorities to pay for this life-saving therapy? So I think it will come. I mean, the last 3 years has been different because of the COVID-19 situation, which has put programs on hold many places.
Yes.
On the other hand, we have seen an increase of the number of TAVI during the COVID-19 because the surgical wards was closed down and the ICU was not available. So more and more patients came forward for TAVI with us. So it's different from side to side, and I know that in Hong Kong, you're still recovering fully for TAVI, so maybe from COVID, so maybe it will come in a few years. And also, as I said, remember this baby boom after the war. These patients are now coming into their 70s, and so you'll see much more patients coming forward in that age group, and this is the age group where aortic stenosis starts to be symptomatic.
Great, thank you.
Yes. Hi, Lars. Yeah, this is Ivan. Nice to see you again after the London Valve. Just the topic on the design of the TAVI device. So we know that there is a few of the novel TAVI valve that have the dry tissue valve technology that they can be already preloaded and was loaded in the package and without the time and the cost for the loading during the case. So what do you see in the potentials of the dry valve technology?
I see some potential. I would say for some of these valves we're using today, loading is not a big issue. It's quite quickly to load them. It only takes a few minutes. And dry tissue also often allow you to go to a smaller profile. I think nowadays most valves going in a profile similar to a 14 French sheet, so we can access the femoral arteries in at least 95%. So I personally don't see a big need for saving those few minutes for loading in the cath lab and those 2 friends, because that's not needed in most patients. And also what I want to see before we actually move to this dry seal is the durability really the same as for valve which has been preserved in a wet environment? And I think we cannot compromise on durability because we are expanding to patients with longer life expectancy. We need good durability of these valves. So I'll be watching this field a little bit skeptic and see whether the first data on these dry tissues valve will come out with durability at the same rate as we see for other valves on the market.
Hi, Lars. This is Vincent. So I'm sure that you have been to this area of the world a lot, especially like back in China. You have proctored, many cases to many centers. So some uniqueness about aortic stenosis in this locality, namely there may be more bicuspid valves, we have more calcification, and many of the time we even have rheumatic cases. Do you see that those can be tackled by conventional valve that we have been using worldwide, or we should have like a special designed valves in Asia to tackle these unique characteristics in severe AS?
It's a very good question, Vincent. Yes, if you go to Asia, you see much more patients coming forward with bicuspid aortic valve, and where we mostly see patients with type 1 in the Western world, it's more common to see type 0 in Asia, and also very calcified valve. And so we need, and that's going to be the same if you expand TAVI to younger patients in the Western world, even though it's a type 1, we're going to see more and more patients coming forward with bicuspid aortic valve. And all the evidence we got today is on tricuspid aortic valve. So maybe we need a different valve design to tackle that. It could also be a different approach. We have seen this leaflet modification with the basilica, or now this shortcut to try to lacerate or cut a leaflet. And it could potentially be used in a bicuspid valve. Try to make it tricuspid before you implant the valve. That could potentially also change it. I don't know how it's going to move something. Sometimes concepts developed out of something you say will never be possible. Just look at the transcaval approach. When you saw that first time, you said this is never going to work. This is crazy. People starting fracturing surgical valves, and you again, how can they do it? Now everyone is doing it. So I think maybe there will be some quite simple concept to tackle bicuspid aortic valve, not only by valve design, but as I said, maybe leaflet modification, make a bicuspid valve into a kind of a tricuspid valve before you do your valve implantation. But let's see.
Is there any more questions? If no, okay, I would like to conclude this session. So thank you once again, Lars. You give us a very excellent lecture talking about the past and the current and the future status of the TAVI. As usual, we learn a lot from you. But please stay tuned here. We would like to have, with all four, we would like to have a picture with you. But I need to close this session first. I would like to invite all of you to give applause to Lars for the lecture. Thank you. Please stay tuned. Please join us for the last session of this AP Care Symposium, which will start at 3:45 p.m. Hong Kong time. We will have 4 wonderful cases of complication from experts talking about involving TAVI and LL. So stay tuned and see you soon. Thank you once again. Bye-bye.